Hi, everyone. So I'm going to start by just saying thank you very much to the P2 Collaborative for the opportunity for me to join this panel, because this is important, it's meaningful, and it's really incredibly timely. So I want to begin by saying my name is Jaclyn McGinley. I'm a licensed master social worker, so I provide a little bit of a different perspective, I think, to the conversation here. But most importantly, I'm here on behalf of Dr. Deborah Waldrop, who is my mentor and a distinguished member of the University of Buffalo School of Social Work faculty. She is deeply regretful that she cannot be here today due to a medical family emergency. And as I said to her, I think if there was ever an audience that could understand that reality, it is this audience. But what I'm going to do is do my best to share our insights from a preliminary review of the literature and what is available out there as we ourselves are preparing to ask primary care physicians how they are engaging in advanced care planning in their own practice and the barriers and the facilitators they see to that. So my charge here today is to provide you with information regarding billing, workflow, and the use of interdisciplinary teams to facilitate those conversations. My focus is going to be on Medicare's Advanced Care Planning Codes, which took effect on January 1st of this year, which now are allowing physicians and other qualified healthcare providers across a variety of settings to report and be reimbursed for those timed services. I believe in your packet you should have the Institute of Healthcare Improvements handout, which is a wonderful tool guide. It's a 2-page document that is sort of a cheat sheet for some of the coding and billing requirements. Because there is such variability across local providers and insurance carriers, I've limited my time to Medicare. But if you have questions about a specific provider or carrier that you partner with, please let me know and we can exchange information so I can get you the information you need. But beyond this charge, my real hope is to raise questions to you. Because what I want to do is to get you thinking about what model that can serve as a best practice you can take forth into your work, and so that we are offering the best possible services to our patients and to the people that love them as they experience a serious illness and reach end of life. So as it relates to billing, as I mentioned, CMS added additional codes to the physician fee schedule as of January 1st, 2016. So there is code 99497, and that's for advanced care planning, including the explanation and discussion of advanced directives by the physician or other qualified healthcare professionals. These are face-to-face conversations. They can be with a patient, a family member, or a surrogate. So that's important to remember, is that there's an or there. It can be any one of those individuals. And that it applies to the first 30 minutes of the conversation. I loved the tip earlier about scheduling those for end of day, so that as we talk about workflow, you can think about when you can do more than the 7-minute in and out conversation, but actually be having the 30 minutes that are eligible under this code. What's great in addition to that code is code number 99498. It can be listed separately and it allows for additional 30 minutes, because these are not conversations, right, that can be had one time in 30 minutes. What I feel is that these are largely reflective of best practices, as I mentioned. So 30 minutes is the minimum benchmark in the research for having these conversations, but they also allow for going beyond that. What they in addition do is that there's not a limit on the number of times you can use this code with a particular patient. So you can be having these conversations multiple times throughout the life course, and I'll talk a little bit more about that. There are numerous services that are popping up that are offering trainings on these codes. So if you have a billing specialist that would like more information on them, an advisor such as Coding Advisor is one that just happened to pop up on our radar recently, is a resource for you to receive additional training or to the members of your staff. But what I want to say is that we did a study after these codes came out, and they found that actually only 14% of doctors or physicians in practice were utilizing these codes. So it's striking to think about what is it that's causing people to not be utilizing what is available to them. And I think when I talk about workflow, when we think about lack of time, right? And when I talk about I don't feel entirely comfortable with this, and we think about an interdisciplinary team approach, there are strategies that will enable you to be utilizing these codes, not because you can get reimbursed, but because these are meaningful and important conversations to be having. So, talking briefly about workflow, I want to ask you, when do these conversations happen in your practice? Research has suggested, and many people have echoed, that they either never happen or that they often happen too late. It also begs us to ask the question, when should they happen? So in your own practice setting, when do you think these conversations should be happening? Research suggests they should be happening multiple times over the life course. So is that annually, at every annual checkup or a regular visit, if you're with a social worker? Is it with a status or prognosis change? Is it with a new diagnosis? Or really, is it all of the above? And what we know, as I mentioned earlier, is that Medicare's new codes do allow you to have multiple conversations with each of those changes. There has been one, when we think about workflow, one pilot study where there were prompts built into electronic medical records, an email and a visual prompt that allowed the physician or whomever was working with the patient to be reminded, there's a new diagnosis here, or this is the annual checkup. Do you want to engage in that advanced directive conversation, that advanced care planning conversation? So that's a strategy you can think about integrating into your practice and into your workflow. And then the last point I want to make relates to the interdisciplinary team. Medicare's new rule allows for other individuals besides solely the physician to be having these conversations. So nurse practitioners, physician assistants can be billing for these services. There's also, and on the handout it does provide you with some guidance, there are additional individuals who maybe can be serving to help facilitate those conversations at the midpoint. So perhaps the doctor introduces it, perhaps they come back and check in, but in between, could a social worker or a nurse be engaging in some of the conversations as well? I encourage you to think deeply about what your patients want. The research seems to suggest that an individualized approach is best. They might like multiple people in multiple different ways having these conversations. They may also like to be having that conversation with the doctor or maybe the social worker, whomever it is, figuring out what is best for that client or that patient. And then last, I encourage you to think about the fact that once you identify who is most able and capable of having those conversations in your practice, do they have the support necessary to have those conversations, right? We learned earlier that simply because somebody has progressed through a certain level of training, it doesn't mean that they have been introduced to these subjects. 29% of physicians reported that they had had some level of training in end-of-life care. That's only 29%. So do your staff have the skills and support necessary to be doing this work if you are asking them to do it in practice? And that may look like training them in intervention techniques. It may also look like ongoing education that engages with simulated activities like we have today as an opportunity so that they are best able to facilitate those conversations. And I want to thank you all so much for listening to the closing presenter on this panel, and I'll turn it over for the questions.
Thank our panel very much, and especially thanks to Jackie McGinley for coming all the way from Rochester to fill in for Deborah Waldrop. So we have about, I think, a half hour or so until our next break for questions to the panel members, and also I think to Katie Grimm and Krista Gottlieb. So anybody in the audience can start off with questions. We have somebody with a mic who's in the back of the room who can run around for questions. Figure out how to turn this on. Let's figure that out. Okay, so we're hoping we have a lot of questions and a lot of interaction. We've had a really good set of panel presenters and also Katie Grimm and Krista Gottlieb. So let's spend the next half hour getting some discussion going from the audience.
Hi, I know a lot of my clients have tended to avoid hospice because they say that They don't allow food, they don't have water. Is this a myth? Is this something that is done in certain circumstances, or I'm not really clear on how to advise them?
Can I ask also for questions from the audience, if you would please just stand and introduce yourself, and then if you have a specific person that you would like to address your question to, although I think for now that's probably going to go to Deborah Luczkiewicz.
That's a myth. So hospice doesn't starve people. But people do stop eating and stop drinking as they get closer to end of life. And I think a lot of the perception is that we don't make people eat, we don't force people to eat, we don't generally provide artificial nutrition and hydration just because someone stopped eating. But within that kind of context of goals and situations, you know, if somebody has, if somebody's not eating because that's the point where they are in their end of life decline, forcing them to eat, providing nutrition and hydration artificially provides no benefit. But if someone can't eat, let's say because they have a tumor blocking their throat, that's a different situation. And there we might consider things like peg tubes and things like that. I often say starvation is when you feel hungry and can't get food. That's not the case when you're dying. When you're dying, it's a natural part of the process to eat less and less, sleep more and more, and the body kind of knows how much it can handle and the appetite will match. So we encourage people to eat and drink whatever they want, however much they want, but we don't force them to take more than that. So that's kind of, I know there's a lot of misperceptions. One of our sayings that we sometimes quote is that people aren't dying because they're not eating because they're dying. And that sometimes helps put things in perspective.
The other thing, hospice does a really great job working with the entire family, which isn't always the case in a hospital setting. So they make it very comfortable for family members to be there and be in the rooms, and they have kitchens, and I mean, we had plenty of wine in our room. So you can bring anything you need in.
And just in my experience, working with people, all of my patients died because I worked in institutional long-term care geriatrics. And very often people simply had very specific requests about what they wanted to eat, and so you fed them what they wanted as opposed to what we thought they ought to be eating. And so it becomes really comfort food at the end of life. And as Deb said, I think they are not eating because they're dying as opposed to dying because they're not eating. Dr. McCune?
Good morning. I'm a primary care family physician in the long-term care setting with nursing home patients exclusively, and I have these conversations at least weekly, sometimes daily. I have a comment and a question of a legal matter. So the comment is that my big trigger for having what I call family meetings, where we bring in all the stakeholders, as many as we can gather with the patient, is when I see that there's a big gap between reality and what they seem to be expecting, and maybe not stating the goals as we're hearing about today. And so that triggers, we need to bring them in. So my question is, when we have an advanced directive that says, I want to have comfort measures, I don't want to go to the hospital, I don't want to have those aggressive measures, and the patient now loses the ability to express themselves any longer, and then the healthcare proxy decides that they do want to do those things. I understand that legally we can still go by the molds, but practically the family has to be dealt with. And I'll honestly say that my fear is that if I don't follow family directions in that setting, I'll be more liable for a lawsuit later on. And so that's my question for our legal minds here is, what is the exact legal standing, and then how do you put that into practical practice in our litigious society? Thanks.
I think the question is how to prevent the possibility of a lawsuit as opposed to what needs to be done in order to address the issues for this family. And the two may be the same thing. One of the things that's very evident from the research I've seen is that the more time you spend talking to people, the less likely they are to sue you. Meaning, and I mean that specifically for doctors, that one of the things that goes to, whether it's medical malpractice or other lawsuits against doctors, is because people feel that they are not known, are not understood, and feel free to sue the person who they're not understood by or giving information. So I think one of the important components that addresses both issues is talk to everybody. So you have a person who can no longer address their preferences, but that doesn't mean they've never done so with their family. It also doesn't mean that their family doesn't know that family member in a way that would give them clues as to what that family member would really want. So that's where you're in a position to facilitate a conversation, no longer involving the person that the decision is going to be made about, but involving the conversation between the people who will be making that decision. That being legally the healthcare proxy and the other folks. So my answer to your question is you engage the decision maker that you are legally obligated to follow, unless there is some other appointment of a guardian. You can encourage guardianship proceedings where somebody would be appointed, which is a way level above. So if there is a real controversy and you're really concerned about liability, then you'd want to suggest the possibility of a guardianship, and in that case, the guardian would then become the decision maker, but you still come full circle to, will it be representative of the party's real intentions? And so my answer would be facilitate the discussion as much as possible, elicit as much information about what you think, what they know, what they think they know from knowing the person they would have really wanted and guiding them down that path. But in terms of legalities, there are some specific things that flow from that. If you were to literally disobey, it would be the same thing as disobeying a patient when somebody stands in their stead. But so facilitate the discussion to hopefully avoid the necessity and make everybody feel comfortable that what's really happening is not a contravention of their desires, but simply an execution of what would have otherwise been the person's wishes. Does that help in any way?
It doesn't account for the emotionally charged family members that don't want to give up, and they're still in that emotional thing. You can spend hours with them, and they still won't. I had one woman one time, she was
In her 90s and had a pacemaker, and they're still wanting to do all these things and not accept reality. And the MOLST form, no hospital, and I'd had conversations with the patient. She didn't want to go, but the daughter's there, calls the 911 herself from the patient's room, and the ambulance is there, and the patient, no, I don't want to do this. The daughter says, Mom, you're going. And the ambulance people are looking to me, what do we do? Because we can't take someone against their will. Is this patient competent and capable of making these decisions? And so, yes, I agree. The more time you can spend with people, which is difficult to do in and of itself, is important. But there's these situations where it's just crazy, and it just happens because you have to give in. I don't I don't know any other way, and I see people nodding their heads here. I'm sure many of us have been in those situations.
Well, I think what you're describing there would be a direct conflict between the actually affected person and the daughter. So if she's saying, no, I don't want to go, unless you think she's incompetent or does not have capacity in that instance, then you have to consider what the daughter says. If she in fact has capacity, then she is in control, and she's the one who gets to make that decision. So it really becomes a question of if she's unconscious, then it's a different conversation than when she's saying, I know she wants me to go, I don't want to go. And if you're the decision maker, that leaves it with you if you cannot facilitate the change of mind. And you're right, like I said before, there will be people who will simply never accept certain things, and then they will blame you for them. So the more you can get them engaged in that decision-making process may give you some additional protection.
I think legally, though, you are not at fault if you follow that person's molds. I work for the VA, the land of legality and federal bureaucracy and red tape and all kinds of ugliness. So I talk to our lawyers, and they will stand by the fact that if we follow the molds, if you do any other things, you can actually be found guilty of assault. So technically, no one's really going to do that, but technically, you are legally saved by the fact that you are following that person's wishes. But good luck with that family member. I don't know.
Well, I'm a nurse case manager with Independent Health, and I'm a former hospice nurse, and I think my question is for Dr. Hartman. Having dealt with several family members who've had devastating illnesses, but most recently, my father, who ended up in hospice care, and it was the way it should have been, but prior, during the diagnostic phase, during, a few hospitalizations for various things, there was good communication between the primary care doctor and the specialist, but now he's in the hospital and you're dealing with hospitalists who have not had any of those conversations, who don't know, and then are planting seeds with him that are probably unrealistic. How do you deal with that gap, that barrier?
Well, we have direct communication with 3 hospitalist groups that work directly with us. And each one of them has electronic access into our medical records so that they can see everything that's been documented in real time. They also have our own cell phone numbers they can personally do. There's a HIPAA compliant way they can text us and we will call them and communicate with them. Part of what we have done is told them that every hospital admission we need to be notified if there's any question of anything. You are to call us or one of us on call. If I happen to be gone and Dr. Sharif is on call, we have electronic access to our records anywhere basically you can have the internet around the world. We can get on and answer these questions. Part of our signing agreements with them is that they must communicate with us every time a patient's admitted. Sometimes it's simply an email from them that this person was admitted, this is what the plan is right now, and this is what we're planning on doing. You can send them back if you agree. If you disagree, you can say, well, call me, we need to discuss. That we will get called back, we will discuss it. So it took a little bit for them to be able to, because they're in the hospital, to get HIPAA compliant and security issues so that they can directly access for firewall issues and all that. But we've been able to do that through both the CLIDA and the Catholic system. So we have people at not every hospital in town, but we have people at 3 hospitals that allow probably over, 90%. We have that direct conversation with Kenmore Mercy because we're in Amherst, but we have one with Suburban and we have one with Sisters that we meet with on a regular basis. We have face-to-face conversations with them. Yeah, is something going to slip through the cracks? Yeah, occasionally. But for the most part, as a matter of fact, one group was not communicating with us on a regular basis, and we threatened to fire them, and all of a sudden communication was 1,000%. So it worked well. I don't know if you want to direct how you communicate.
Yeah, I think this is a team-based approach, and we have a dedicated nurse in our own office who chases all these high-risk patients, and patients who have been admitted. Make sure that they've been taken care of. And we encourage patients to call us up. We're always available when there's an issue like that. Definitely we need to get involved. And like Dr. Hartman says, we've got very close communication with the hospitals. We talk to them, we bring them to our office, make sure they pay for the lunch too. But we do discuss with them.
Monday everyone's going to call to switch to your practice. Truly, I mean, you guys are exceptionally rare. And in the mental health field, that have the same issues with the mental health system as well. The vast majority of therapists, psychiatrists, and doctors do not communicate with patients. And so is there any advice for how we kind of can make that happen? Because you guys are definitely a model for how we would like to see that happen.
I always say that the communication is the essential thread in the fabric of patient-centeredness. When we applied for NCQA, we made sure that we overhauled our practice and put the team-based approach into our office. Yes, there are cases when things fall to the crack, but we try our level best. And I don't think we're going to accept any more patients. Our panels are closed.
part of that communication, hopefully, if somebody gets admitted to the hospital, the patient knows what their wishes are and whoever may be accompanying them, because we've had that discussion already. And so hopefully they will disseminate that and then say, if there's any questions, call my physician. One case did arise where I did some preoperative stuff on somebody. They were going to have something, they were diabetic, they needed to have some stuff, and I says, you make sure you tell them this is what needs to be done post-op. Well, the nurse came in and said, the doctor wrote this, and the patient refused to have it done and said, you need to call Dr. Hartman directly. And they got upset, and so the doctor called and I said, did you read my pre-op assessment? And they said, yeah, and I said, well, what does it say on line 4? Because I'm sitting there right in front of me under this diagnosis. And I said, that's what you need to do. So hopefully, you know, if you're communicating well with your patient, you tell them, and you're all on the same wavelength. When they get in, if something's going to happen that doesn't seem to go in view of what they want, or a family member, then they will hopefully press a red button too. But the other thing is that if people don't communicate with us, we don't use that group. If you as a specialist are not going to communicate back with me and accept my communication to you, you're getting no referrals from us. And that tends to, wow. Yeah, so.
Comments and then a couple questions. Lee, I feel your pain, having been there. Just a quick comment on the legal lines and when you have a good most. I do have a colleague who actually threatened an EMT with an assault charge if he started a DNR on a dying patient once. The EMTs did not start the cut. The patient expired peacefully in a nursing home. So there's a precedent for doing it, at least locally. I just wanted to get an idea as a physician, how many physicians, NPs or PAs are here today? Awesome. How many nurses? How many social workers? How many people who would describe yourself as care or case managers? Great. I just wanted to get a comment maybe from all the panelists, including the non-providers, about where you draw, though I'm a palliative care physician, long-term care physician now, a payer, chief medical officer, and PACE clinic medical director, so I've done most of this. I'd like to get an idea of where you as panelists expect your team, your interdisciplinary team, to take responsibility for this, and how many of you see yourselves as the primary initiator, or if you've got a designated initiator about discussions, or if it's a shared responsibility.
So I have a social worker, I have a clinical nurse expert, I have a chaplain, I have residents, medical students, a whole slew of people on my team. And I think that's a great question. As to who initiates it, when I get a consult, I will not see that patient unless the primary team has already had a discussion. I will cancel it, and I will say to them, have you talked to your patient? Because I'm coming in, just like Dr. Grimm said, is the Grimm Reaper, Debbie Downer, whatever you want to call me. I have a lot of names. So when I come in, and I'm happy to be there and assist them with that discussion, but I will not run that meeting, because how am I going to graduate you as a physician if you can't do it? And hiding behind the curtain is no good, or being on your cell phone. And I've actually had a surgeon last week page himself out of a meeting. I watched him dial his pager, he got paged and then left. I was like, oh no. So I will not have those discussions. And then, but there is no one person on my team that I will say to have those discussions. My social worker can have a discussion better than most physicians. So if I'm in a bind and I need help because I have 10 consults, I'll say, hey, Nancy, can you please go help me with this? Because I know there's not some symptom management that I need to do. So I think I use my entire team, even the chaplain. If I think that they're spiritually suffering and, you know, maybe I'm not getting anywhere with that person because maybe I just don't understand things. And I know that Melody, I know Dr. Case has told me several cases where you have been integral. Melody is part of the chaplaincy pastoral care over at Roswell to help facilitate those discussions. So I think you have to feel out your patient. But for me, if I didn't have my team, I'd be nothing. So I don't know how you guys all deal with it, but I'll pull to maybe you guys. I don't know about your team.
I personally initiate every discussion. The key for me is anytime they get a new chronic diagnosis, usually it's not at the time of the diagnosis, but it's at this second follow-up visit is when I'll start, when they've stabilized and they've had time to digest what the disease is and sort of know about it a little bit, because it's very difficult to start that kind of stuff. So every time I started, there were other people that may continue it at the office, but I initiate everyone, and I feel it's my responsibility because I know them the best. I've probably made the diagnosis, and you know, if it is a nasty one, they've been with the specialist, and so I've got communication back, but I initiate everyone personally.
I think that's the difference because I'm a consultant. So do I come in and have primary care physicians and hospitalists do those conversations? No, I don't know why it doesn't happen, but it doesn't. And I get told it's a time constraint. So, I mean, like, I hail to.
So that's why we're behind a lot in the office, I'm sorry.
I guess in hospice, it's very much an interdisciplinary team approach. When I work at the inpatient unit, so I find we have patients coming to us directly from hospitals, directly at admission to hospice, so I'm always sort of feeling out where we stand with understanding of illness and advanced directives. If someone comes with a MOLST, I will review it with the patient. Very often my patients are not in a situation where they can have the discussion, at least initially. And so I will talk to families. I want to make sure the family members, the proxy, the surrogate, whoever is there, the children are aware of what the MOLST says, because often mom has filled that out in a hospitalization. And this is the first time the kids are really getting involved, or they've come from out of town. So I try to review that just to make sure everyone's on the same page. I think as far as the law, you know, a proxy is supposed to honor the patient's wishes. And so I try to emphasize that as well, that your role as proxy is to make sure your mom's wishes are carried out. These are the wishes that she has already told us about. And unless the situation changes, the proxy is not supposed to change the wishes. So that's part of the discussion. But I try to review that when I'm meeting a family for the first time. And, you know, they may have been dealing with a chronic illness for 10 years and they know a lot more about it than I do, or it may be a new diagnosis just a week ago and everybody's still in shock. So, but within hospice, the social workers have these conversations. The nurses will sometimes come to me and say so-and-so is ready to fill out a proxy or was talking about wanting to change their proxy. So it's very much a shared responsibility.
There is one thing we do in our offices before the patients are put in by the nurses. The nurses do ask this question, apart from whether you're a smoker and peak, whatever the thing about mental health is. The third question is, do you have a healthcare proxy? All the patients are asked this question all the time.
Can I answer your question directly? So I want to just say one thing, just because I work in a totally different patient environment. So I do have a team. I think I echo everyone up there. I think this whole conference is trying to shift this perspective to, as Dr. Hartman said, you know, this is a primary level conversation that has to happen with the person that the patient trusts the most. So I just want to mention that just because it's hard in this interdisciplinary thinking that we have in the population that I deal with. We also have to figure out who, and I work at ECMC, largely African American, who that person trusts the most in that team. And often I will tell you it may be the African American chaplain, just because there's a shared identity there. So I think if you start from the premise of patient-centeredness, the answer may be easier to get to. That's, you know, my view of the team. But I agree, it's this the palliative care physicians in the room would identify with this. You know, we're recognizing and we realize that palliative care is a primary practice that needs to be spread throughout the continuum. That's why we're here. It's a continuum.
Private practice, so I am that lone ranger with, I think you said, without my team I'd be nothing, and there are many times when that's how it feels. So, and I have a master's level degree, so I am not a doctor. So my experience of trying as a professional or on a personal level being a patient advocate for someone to get a doctor or a psychiatrist or anyone to talk to me or return phone calls is next to impossible. So what I have done after I wrote my books is approached literally all of the campuses in Western New York and tried to speak to med and nursing and counselors in their training before they get out in the field to try to make an impact there. It's the only way that I have tried to overcome kind of being the Lone Ranger thing, is to try to make an impact on a personal level before they go out in the field.
My name is Holly Shepard, and I'm a case manager in the insurance end of things. And we speak telephonically to people on the phone. And one of our biggest struggles is we can see kind of the big picture. We're seeing all the claims come in. We're seeing the multiple hospitalizations and things. But what we also have difficulty with is, for instance, a cancer patient who hasn't even seen their primary care doctor since they began their treatment. And, we're trying to rein them back in, do you see your primary? Can you see your primary? How do we continue to keep the primary care involved once they get off to the specialists, I guess, is a big struggle that we see. And I don't really know how to grasp that or even have you comment on it, but I just wanted to make that observation that, from an outside perspective, we're trying desperately to get them to go back to the primary care so we can have a quarterback or someone so they're not jumping. And I just wanted to make that comment, I guess.
Well, we certainly see that in our office as a major problem. Like Dr. Shreve said, we have somebody who, a full-time nurse whose job is to call these people up and stuff. The problem is usually once they get to a facility, without mentioning names, one in particular, they get sort of devoured in the bowels of the situation. And for us to get communication is haphazard half the time. The communication's not sent to us for whatever reason. If we make phone calls there, our phone calls are never returned. And the patient is now going up there, 3 days a week for them, and they're ill, and for them and their family members to try to fit us in when we're, quote, not doing the treatment at the time, to try to convince them of the value of coming in to make sure that everybody's on the same wavelength is extremely difficult. I know our nurse makes a phone call to every one of those people within 48 hours. I mean, we probably even need to hire somebody else just to do that. But to get them in is like pulling teeth.
My name is Judy Reestack. I'm with Impala Faith. I retired. Thank you. When I retired, I wanted to take the Faith Community Nurse course, which I did. I've been involved with 2 churches, and I help people in the homes when it's time for them to go into hospice. Currently, I have just started with a nursing home hospice under the chaplain, trying to bring in the spiritual model stronger with the medical model. I see a big door opening for this kind of service for nursing. It's been very gratifying for me in helping her. She really is determined to try to get more of us in the nursing home, hospice, or maybe just the regular nursing home to bring in that type of spiritual model. I have one question, which I just found out recently. When a person is in the home, hospice comes in, that is paid for by Medicare, Medicaid. There is sometimes a misconception when they go into the hospice unit in the nursing home, they have to pay for room and board, which many times this has not been communicated. So that is so vital. They think that Medicare or Medicaid is going to pay for it, and it won't. So I just wanted to make sure that that is very well known. Thank you.
The the payment issues are always confusing, I think, because insurance pays for rehab stays in nursing homes. There's a perception that when somebody needs custodial care or end-of-life care in a nursing home, that that's going to be paid for as well, and unfortunately, it's not. The hospice services provided in a nursing home are similar to what's in the home. Someone coming in to provide case management, home health aides, whatever is needed, but the room and board is still the responsibility of either the patient, the family, or Medicaid if there isn't another payer source. So maybe we could do a little better with the education.
Thank you.
Hi, my name is Jill Nestico. I'm a nurse practitioner at Roswell Park, the other institution. I would just like to sort of address your concern. I work in solid tumor and medical oncology, and I can assure you, I tell my patients all the time, you need to stay with your primary care doctor. You need to see them. You have other health issues. We're not managing them. We're managing your cancer. Unfortunately, these people are so burdened with the number of visits they need to take care of their cancer. The thought of seeing another doctor, even if it's their primary, is exhausting to them. So I'm not going to disagree that there might be certain tumor types, bone marrow transplant. They're very involved with those patients. They're very, very ill. And yes, they may get followed up. But I can tell you, at least in solid tumor, we're not dealing with all those other treatments. We want them to see the doctor because they will call us for every little thing. And we tell them, you have a primary, and if you don't, you need to get one. They're going to manage you. So if it has come across that way, I can assure you that it's not the intent. And if there's been a communication problem, and I know patients tell me, oh, the doctor didn't get your note, and I look at the note and it says it got faxed. Obviously, we need to know about that because we don't want that. We want communication between the primaries and other specialists all the time. I tell doctors all the time when something big is going on with their patient to tell them what is going on. And I don't want us to be living in a little tunnel here. We need everybody to work together with these patients, especially when it's coming to end of life. So I just wanted to address that.
I'm Maggie Macklin, I'm a primary care physician, and we've talked a lot about
palliative care. I have a lot of patients that are healthy but older, and I have the conversation about DNRs with them all the time, because even though I don't expect them to die anytime soon, it's a decision they can't make when it happens. And I would say probably 3/4 of my patients have a DNR that are healthy adults because the prognosis is so poor for out-of-hospital cardiac arrest. That's all I have to say.
All right, we probably have time for one more question. We give it to Bonnie Sunday.
Thank you. I'm Bonnie Sunday. I'm a family doctor. I'm also a medical director of Blue Cross Blue Shield. And my question is a legal one. If you have a patient who has never filled out a healthcare proxy and now is in a situation where they're incapacitated, what is the hierarchy on who can make decisions, who can act as a decision maker, and what decisions can't they make? Because I know IV hydration was an issue, and I believe it still is, and I think it's important for everybody to understand the ramifications if there is not a healthcare proxy, and if certain specific items are not spelled out on the proxy.
Krista, you want to take that?
To the extent that I can, because as I said, I'm not primarily an elder law practitioner, but I think the question is no documentation, no legal documentation whatsoever, who gets to make decisions in that place. Generally speaking, it is the person who has the most direct legal responsibility. So if it is a spouse, is usually the person if there is a spouse. When you get into issues, no. He has a better answer for you.
There's a very distinctive hierarchy.
There you go. So I'm the wrong person to answer the question, and here's the guy who does.
In the state, there's a very distinctive hierarchy of spouse, children. There's guardianship. First, guardian is the primary if there is a guardian, which is rare, but in some cases. and then it walks down a list, and then there are exceptions to the list depending on which, when there are children, and you've got to make sure that you've identified all children, all family members that might, if you're beyond a spouse, brothers and sisters, close family members, and it gets gray about relatives who have the closest contact. There is a list. In the healthcare, it's on the Healthcare Decisions Act. If you look on the Family Healthcare Decisions Act website. There are several places you can find it.
And does that cover feeding and hydration? That was the other
Well,
piece.
the issue covers who can make decisions. So it's basically establishing who can act as proxy, even if there isn't a healthcare proxy.
But if there's no specification about hydration and nutrition, what happens to it? If a family member says they wouldn't want this, but there's nothing in writing about IV hydration or nutrition, then
Which is our most typical situation, right, in almost every environment. It is up to that decision maker as determined by the Family Healthcare Decisions Act. Those decisions they're asked to make those decisions even if they do not understand the pre-existing wishes of the patient.
so that's been changed.
Yes, the Family Healthcare Decisions Act talks about surrogate decision-making, and the standard as of 2010 for a surrogate is that they are supposed to act according to the patient's wishes or in the patient's best interest. So that was written into that law, which is an expansion of what was in the healthcare proxy law. Healthcare proxy law says if the wishes are not known regarding nutrition and hydration, the proxy cannot make that decision. That was clarified in the Healthcare Decisions Act for a surrogate. Now, we are in the situation where those two laws are still in effect, so it's a little bit different standard for a proxy versus a surrogate. And eventually, I'm assuming the courts are going to reconcile those differences. But it's according to known wishes or in the patient's best interest in the case of a surrogate.
All right, I want to thank everybody very much. We're going to have to cut the questions off because we are only going to have about 10 minutes for a break, and then we have a really, really interesting skit presentation followed by some more questions and answers. So there's more to come. 10 minutes, short break, and then we'll all reconvene again. Thanks very much to our panel and to all the questions.